Okay, thanks very much, folks, for joining. Sorry, Caroline, I thought you were reading my mind. Welcome to the Marketplace on WASH and Nutrition. As you know, the Marketplace is one of the more interactive events of the summit, and we'll be listening to stories, ideas, projects that organizations around the world have implemented during the COVID-19 pandemic. We encourage you all to actively participate in the chat to share ideas and questions. And we'll also be working together to unmute folks to participate vocally as well. So the way the session works, I'm Sarah Page. I am the Global Health Security Advisor for Core Group. And Caroline Burke is here as well. She is working with The Difference. Caroline, I'll have you introduce yourself briefly, if you don't mind.
Hi, I'm Caroline. Like Sarah said, I'm with The Difference, and I'll be helping out with technical support. So if you have any problems, just please feel free to privately message me in the Zoom chat.
Thanks. And please introduce yourself in the chat. Let us know where you're coming from. Folks have already done that. So the way the sessions will work is that we'll have our three speakers, or our three sessions, divided into about 18 to 20 minutes each. I'll introduce the first speaker and provide a 1-minute warning when that person's session is wrapping up, and then I'll introduce the second. Again, this 18 minutes, and inform that person when their session's wrapping, in the third. And then I'll just wrap it up at the very end with a couple minutes reflection. And so without further ado, I would like to introduce our first set of speakers. So our first session, we have Goutham, Kandru, and Professor Bhutta. Both are representing Exemplars in Global Health, which is a Gates venture. Goutham will provide a quick introduction to the program at large, and then he'll hand it over to Professor Bhutta. So without any further ado, Goutham, please take it away.
Hey, Sarah, thanks. Appreciate the introduction and excited to be here. As a means of a quick introduction to the program itself, Exemplars in Global Health is an initiative incubated at Gates Ventures, which is the private office of Bill Gates, in partnership with the Bill and Melinda Gates Foundation. So work closely with both organizations and institutions, really around this fundamental premise and set of questions that we often receive from both Bill and Melinda, just around how we look at global progress and deal with global challenges, with the underlying premise being a question of understanding outliers a little bit better. Specifically, for these countries that are making progress at a global scale, how are they doing it? And more importantly, are those lessons replicable at scale? And so on the next slide here, this is just to showcase, while we're going to be speaking specifically about our body of nutrition work, namely stunting, our work actually extends beyond stunting itself to cover other kind of outcomes in global health, including under 5 mortality, and other specific health interventions, be it community health workers or vaccine delivery. And for each of these different topics, and specifically for stunting, in the case of our nutrition work, we have global research heads and well-respected leaders in their field, like Dr. Bhutta himself, along with a dedicated group of technical advisory members who work in conjunction with in-country partner institutions to really unpack for each of these countries and narratives what the true story of change is, what the lessons that we've learned are, and then how we can replicate them going forward. So without any further ado, I'll hand this over to Dr. Bhutta, who can share some of the learnings from our first 5 countries that we've looked at for exemplars in stunting, and then share how these lessons can be applied both in and beyond the COVID context.
So thank you very much, Goutham. So as Goutham said, this work is very much in partnership with the Gates Ventures. We don't work in the office of Bill and Melinda, but we represent a consortium of academic centers located throughout the world, and in particular in this example, in the 5 countries that were targeted in the first phase of this research. And we were guided and supported in this work by a technical advisory group, which is virtually a who's who of people working in public health nutrition. So we wanted very much to see which are the countries that can be called exemplars. And these are those who have achieved a reduction in stunting, represented in the y-axis as an annual compound aggregate reduction. Those who are at the bottom end here, minus 5–6% change annually, are really massive outliers in terms of progress. But we compared these with the economic growth. So clearly countries at this end would be those which have had phenomenal economic growth and therefore no big surprise have achieved changes in health and nutrition. So we wanted to see those who are not here, but those who are more towards this end. And you can see there are a number of countries in here which have achieved change much faster than their economic growth would indicate. So in the first phase, we selected 5 countries for a deep dive based on geography, based on feasibility, and based on external validity in terms of their findings to others in the region. And there are 2 countries in Africa, Senegal and Ethiopia, 1 country in Latin America, Peru, and 1 country in South Asia, Nepal, and 1 in Central Asia that many people don't really know much about, the Kyrgyz Republic. So if you look at what has happened in these countries, there are several ways of doing so. And one such way is by looking at what we call Victoria curves, which is basically for any given cohort of studies, and here these are largely demographic and health surveys, what has been the pattern for linear growth for children between birth and 5 years of age. And as you can see globally, it's fairly well known that children depreciate, that growth depreciates, and by about 2 to 3 years of age, virtually all the stunting that will eventually be there has already set in. So this trough, it represents the depreciation of linear growth, and it's not entirely clear what causes it, but it's a function of environment, food, and perhaps a combination of prenatal factors, but they have not generally been quantified in the manner that we hope to do. So if you look at this example from Peru, it's quite clear that the improvement in Peru's case has been real, that this curve has shifted over time. This yellow here is the most recent demographic and health survey. And not only has it lifted, but the shape has changed and some of this early depreciation has gone away. You can see the same in Kyrgyzstan and Kyrgyz Republic. And notably here, you see a remarkable change in the condition at birth. So very early growth failure, which reflects maybe changes in pregnancy, have improved over time, and progress has been quite steady. And you see this in Nepal also as a gradual set of progresses over time. You see this in Senegal as a slow, steady change, largely in the latter part of infancy. And you see this in Ethiopia also as perhaps something comparable to what you saw in Nepal. So the importance of looking at these curves, growth curves and trajectories over time, is that it gives you a sense of where change has taken place. And as you can see here, the change has been largely throughout the period of early infancy, with a real dose in some places of a change or an improvement in nutritional status at birth, as has been the case in Ethiopia, as has been the case in Nepal, and notably also in the Kyrgyz Republic. The other way of looking at all of this is to look at interventions within and outside the health sector, or which used to be previously called nutrition-specific or nutrition-sensitive sectors. And one way of doing that was to do this decomposition analysis, which we could only do on the basis of actual data in countries. So if you look at this decomposition, it's very clear that you have a combination of things happening, that you have a contribution of various direct health and indirect health sectors, such as reduction in fertility, improvements in health systems, and infant and young child feeding practices. But importantly, you also have contribution from other sectors. Economic improvement, we've already talked about, but things that relate to education, agriculture, social protection, and WASH. And WASH, I would particularly highlight, has been a big moot point, because in some of the traditional randomized controlled trials, you don't see the effect on linear growth, but you see real life, and this is real life, you see experiences over time, and you find that in many of the countries where living conditions have improved over time, that water sanitation hygiene has contributed to between 8 to 17% of the linear growth change over time. You don't see in other places, such as the Kyrgyz Republic, because from a very early stage, they had very high investments and compliance rates with sanitation and hygiene practices. So overall, if you look at this part of the slide, you'll find that the relative contribution of direct and indirect health and non-health sectors is about the same. And if one was to answer the question, what really makes a difference to linear growth in these countries, our efforts in this first phase of the Exemplar project shows you very clearly that it's equal contribution to things that you can do from the traditional health and nutrition sectors, and also things that you can do outside it. We, based on some of these learnings, proposed a framework for how countries should potentially approach stunting at scale, and a 10-step process, which starts with very heavy emphasis on diagnosis. And with granular level information, once a political decision has been made to focus on this, and you want to see subnational data, and you want to see distribution patterns of trends over time. And they then lead to those strategies that I've already identified as direct and indirect health sector interventions and support strategies outside of health. And the importance in putting these together is that this multi-sectoral approach is what makes a difference to growth overall. So if somebody wants to come and ask you, can you give me the one thing that you need to do to reduce stunting? The answer is that one thing is captured in this composite. There isn't a single thing that you do. You do have to do multiple things. You have to do them concurrently, and you can't sequence them also one after the other. We've also looked at the actual evidence behind some of these strategies in countries from which we derived this framework that I've just shared with you. And as you can see, barring a few exceptions where data was limited, but most of these countries have invested in all of these 10 steps at different stages of the development over the last 15 to 20 years. Lastly, are there things within COVID and some of the nutrition risks that we think could be used in reference to our experience in the first phase of this Exemplars project? And we just published these data and this paper last week in AGCN. I'll urge you to look at that. And it looks at the same framework of these basic underlying and immediate drivers that can impact on a range of outcomes, of which stunting is just one piece. So there has already been a publication on wasting in relation to COVID, but I should underscore that one of the biggest drivers of linear growth in this circumstance is the impact in the short term and perhaps in the medium term as this prolongs on maternal nutrition, on girls' fertility, and particularly adolescent girls leaving school and being married off. In looking at this, we've been able to suggest interventions and our 10-step framework that countries can do not only in the short term, but in the medium term as they address some of the challenges of COVID per se. And you will note that these are all related to things that we have been able to point out in terms of risks that can happen within the COVID emergency itself. So I want to stop at this and encourage you to look at our Exemplars website, which is now live as of Tuesday, 30th of June, which has a lot of the detail, the in-depth country studies. We'll have the supplement in AGCN coming out in a few weeks. And let us know if we can support your work in any way further. Thank you very much for your attention.
Thank you very much, Professor. That was really compelling and sort of a neat way to highlight the positive deviance and sort of craft a framework around explaining that. We have about 1.5 or 2 minutes if there are any questions in the chat. Caroline put the website for exemplars.health in the chat.
If there's anything, I'm more than happy to answer either directly or send it my way, and I will.
Great. Okay, excellent. Okay, so thank you very much. We'll go ahead and shift on to our second set of presenters now. We have, let me get their proper descriptions. We have Dr. Asrat and Ms. Caroline Marshall. Dr. Asrat Dibaba is the Chief of Party for ENRICH Maternal Child Health Multi-Country Program, and Caroline is Senior Policy Advisor for Health, and they're both at World Vision Canada. So we'll go ahead and turn it over to you both now.
Thank you very much, Sarah, for the invitation, and we are happy to join this session and present the lessons learned from our multi-country maternally born and child health and nutrition program. And I would like also to take this opportunity and thank Professor Bhutta for his excellent presentation. And I see there are a lot of linkages with what we are going to present and some of their findings from that multi-country program. ENRICH is, just to give you an overview of the program. ENRICH is an acronym which stands for Enhancing Nutrition Services to Improve Maternal and Child Health in Africa and Asia. It's a multi-country program funded by Global Affairs Canada, which aimed at improving the health and nutrition status of mothers, children, and adolescents in select regions of Bangladesh, Kenya, Myanmar, and Tanzania. And ENRICH is implemented by World Vision Canada and Nutrition International, with World Vision Canada as a consortium lead. And the consortium also works closely with other Canadian and international partners, including the Harvest Plus, the Canadian Society for International Health, and University of Toronto. So the overall funding for the program is around 47 million Canadian dollars. And out of that, around 1.4 million is now repurposed for COVID-19 response within the program. And then there is also an unexpected 5 million additional funding to support our COVID response in the implementing countries. There are a total of 1.6 million people who will be directly benefiting from this program in those 4 countries. And then there are also expected 2.1 million people who will be indirectly benefiting from this program. There is also a public engagement component implemented in Canada, where we are trying to improve awareness of Canadians on maternal, newborn, and child health issues of low-income countries. The overall ultimate outcome of the program is to contribute to reduction of maternal and child mortality in targeted regions of those 4 countries in Asia and Africa. And then we have also 3 intermediate outcomes under this ultimate outcome. And then the first one is to improve delivery of gender responsive essential nutrition and health services for mothers, pregnant women, newborns, and children under 2. And now we have modified this intermediate outcome due to the pandemic. And then there will be some interventions incorporated under this intermediate outcome to respond to the pandemic in each country. So under this ultimate outcome, we emphasize on the community-based health systems, and then especially we are trying to improve nutrition of pregnant women, infants, and young children in the first 1,000 days. And we also, under the second outcome, which is increased production, consumption, and utilization of nutritious foods and micronutrient supplements by mothers, pregnant women, and children under 2. Under this outcome, we implement both nutrition-sensitive and nutrition-specific interventions. As Professor Bhutta described earlier, also we are integrating these 2 approaches to improve availability of food at household level, and at the same time also improve nutrition practices among the primary caretakers. In that regard, we educate mothers on appropriate nutrition practices such as exclusive promotion of exclusive breastfeeding, complementary feeding, and also micronutrient supplements. Under the nutrition-sensitive interventions, we promote production of locally available nutritious vegetables and fruits, and as well as we promote biofortified crops by working closely with one of our partners, the Harvest Plus. And then our third intermediate outcome is to strengthen gender-responsive governance, policy, and public engagement on maternal and child health in Canada, and as well as also in those 4 targeted countries. This shows our overall timeline and the key milestones from the launch of the program in March 2016 to the end of this program, which will be September 2021. And due to now the pandemic, we have also integrated a COVID response which started in April 2020 and will extend until end of March 2021. And this is just to give you highlights of the epidemic, the epidemiology of COVID-19 in each country as of July 1st from the Johns Hopkins coronavirus map. As you can see, Bangladesh has among the 4 countries the highest confirmed cases and deaths. And then we have also high confirmed cases, very high confirmed cases in Canada, and also deaths. And then with the global status of over 10 million cases and over half a million deaths. So we're coming to our implementation approach. Our COVID response will augment, enrich current target areas of operation in Bangladesh, Kenya, Myanmar, and Tanzania. And we will also be implementing our COVID response in the nearby areas outside the program catchment area. So the COVID response will extend outside the catchment area. This is a simple graph shows that this is in each country we are implementing in districts, in 1 district, but in Tanzania in 5 districts. So with ENRICH original interventions, we cover the entire districts, but now with COVID, additional COVID responses, we'll be covering also areas outside our primary catchment area. So in total, with our COVID response, we are expecting a total of 6 million individuals to benefit from the various interventions. And out of this, 1.8 million will be women and adolescent girls between 10 to 19 years of age. So the objectives of our ENCORE, ENCORE is now a new acronym for our COVID response, which means Enrich COVID Response. And then the objectives are in line with the WHO objectives. So the first objective is to strengthen community health promotion, to delay, slow, and stop the spread of COVID-19 with a focus on gender-responsive prevention, case detection, testing, contact tracing, isolation, surveillance, and reporting. And then the second objective is to improve health systems and health workforce capacity for provision of optimized treatment and care services of all COVID-19 patients, including also health facility-based infection prevention and control. The last objective is to strengthen community-based social services to minimize the gendered impact of the pandemic on the health system, social services, and economic activity, particularly for women and girls. And then it's under this objective, we will be promoting nutrition and food security during the pandemic. So there are also 4 key activities. The first key activity will focus on preventive measures to increase awareness among our target beneficiaries on how to prevent acquiring COVID-19, the coronavirus infection. And then the second key activity is to strengthen the health system. The public with particular focus on the public health system by distributing PPE and as well as also other equipment. And we will be also promoting wash activities, personal hygiene, by distributing wash facilities at the institutions as well as also in the communities. And then the third activity is to train and equip public health systems and service providers to deliver gender-responsive COVID-19 prevention, detection, treatment, and surveillance services. For this, we are sponsoring training of health workers and community health workers as well on COVID-19 related training. And then the last activity is to promote holistic multi-sectoral support to women, adolescent girls, and children and their families to mitigate secondary impacts of COVID-19, including sexual gender-based violence, negative usage, nutrition, and livelihood outcomes. So just to share with you some of our achievements so far. In some countries, we have facilitated advanced distribution of micronutrient powders to children between 6 to 23 months so that the mothers will not be coming to the health facilities frequently, so that with that advanced distribution, we can reduce exposure and risk of infection. And the second one, we are also in collaboration with the government. We are mapping with the individuals who are at a higher risk and most vulnerable, especially the most of the poor households and households with women and adolescent girls and people with disabilities. And this segment is prioritized for distribution of food and water and hygiene and sanitation kit supplies. And then the last one is we are scaling up procurement and distribution of agroecological inputs, specifically the fast-growing varieties of vegetables and fruits, seeders and biofortified crops. We also distribute chicken wherever possible. For example, in this picture, you could see, the wall murals which are depicting proper hand washing practices in Kenya, and these are some PPE we supply to the health facilities in Myanmar, and then we sponsor also coordination meetings at the county level among the various stakeholders to facilitate planning of COVID-19 response. And also we train in the field farmers on how to prevent themselves from COVID-19 coronavirus infection. So the other activity, we are also working closely with the government and our World Vision local offices to ensure that those most vulnerable households are supported with the required inputs, including unrestricted cash transfer mechanisms for women and adolescent girls and persons with disabilities. And there is also conditional cash transfer for food and other paid health services. We have adapted, for example, this is a positive deviance health session where we facilitate to rehabilitate children with moderate malnutrition. And pre-COVID era, usually we admit 10 mothers with malnourished children in a PD health session, but post-COVID, just to reduce the transmission, we have reduced the number of mothers admitted to each session in 2 to 4, and we ensure also all the protective measures, including 6 feet distance between the mothers and use of face mask, as well as also hand washing facility. That this is how we are adapting our positive deviance or health approach during COVID era to ensure that moderately malnourished children are rehabilitated, and this service has continued in the communities. And we also distribute biofortified crops. For example, here, these are in Kenya, farmers receiving biofortified orange flesh sweet potato vines. So we have increased target population during the COVID era so that farmers could grow orange flesh sweet potato, which takes 2 to 3 months to mature, so that this orange flesh potato could be available at household level to increase their household food security. These are some photos showing our COVID-19 response activities. For example, this is distanced community distribution of jerry cans. So we have distributed water jerry cans and other sanitation materials to the most vulnerable households in the target areas, and training on livestock practices, ensuring all protective measures. And we also support primarily women to cultivate biofortified crops, as well as agroecologically appropriate vegetables and fruits, so that to ensure that the household is accessing adequate food during the COVID era. And we also train farmers on poultry, ensuring all protective measures so that we minimize the risk of infection. So that's in brief, how we are, ENRICH project is pivoting in this COVID-19, ensuring that we still are able to provide the maternal and child health intervention services, at the same time also respond to the epidemic in each country. So maybe I would give chance for my colleague Caroline to say the things and also facilitate the Q&A session.
Great, thank you so much for that, Dr. Dibaba. I think that really reinforces what many of us have seen about the importance of making nutrition and food security a critical component of COVID-19 response and recovery. So we'd love to hear from you now if you have any questions for Dr. Dibaba, and also if you would just like to share with us what your grant programs or other funded initiatives are doing to adapt to the new realities of COVID-19, because I think a lot of us are having to really modify some of our approaches. As you saw in the photos that were presented, we are using masks, we're distancing the interventions and the individuals, and we'd love to hear from you about how you're approaching your work. And you can always reach out to us at other times as well if you don't have any questions. The other thing that I've just put in the chat box is a link to the 1000-Day Journey website, which, as Dr. Dibaba mentioned earlier, is our public engagement component of the grant, and is one of the methods that we use for communicating the importance of programs like ENRICH, especially within the context of COVID-19 and the importance of continuing these activities.
Hi, Caroline. This is Sarah. I'm going to take facilitator privilege and throw out a question. Oh, we have Sarah Schultz as well. Can you share how these changes and approaches during COVID may continue in your programming for the long term? That's for you, Caroline, and Dr. Dibaba.
Yeah, this is a very good question. The COVID-19. We have learned a lot of things. I think everyone has learned many things from the challenge. So moving forward, as I mentioned earlier, our COVID response will be about a year, or just less than a year, with additional funding. And then this will give us a good chance on how to respond, to learn on how to respond on similar challenges, epidemics in the future. So it will be a very good testing time and period for us on how to integrate pandemic responses and development programs and pivot quickly to save lives. In addition, we are anticipating a second phase of this program following the September 2021 closeout, and definitely the design of the second phase program will focus mostly on recovery. How to, there will be a lot of setback, and as Professor mentioned, stunting is also a key area we work on, but stunting, wasting, and underweight, those prevalences might increase as a result of this pandemic in each country, especially in our target countries. So definitely the design will take considerations of the impact of this pandemic in each country, the lessons learned, and then it will be a very good chance to improve the lives of the target people impacted by the pandemic. So the recovery will be a very good chance for us to, this implementation period, to learn and also design accordingly very effective second phase program.
Great. We've reached our time limit for this, for session 2. There are some magnificent questions in the chat box that I hope we can come back to maybe at the end if we have some remaining time. This question about vulnerability is excellent. This question about locust invasion and how that's affected support. So I'm going to sort of keep those in the back of my mind, and want to say thank you very much, Caroline and Dr. Dibaba, for that great description of sort of how ENRICH has pivoted to ENCORE, and that sort of dovetailed nicely with the previous Professor Bhutta's presentation. That's the larger framework, and so we can kind of see how those integrate in terms of multi-sectoral support to vulnerable communities. So at this point, we will move to our final presentation, which is entitled MUSEFO, Care Groups on Facebook, Ensuring Engagement During the Pandemic. And the presenters we have 3 presenters, and they'll also have a video session. So Armel Satcher is the Social and Behavior Change and Gender Transformation Senior Advisor at Action Hunger in USA. She provides technical support on behavior change for nutrition, health, water, sanitation and hygiene, and food security and livelihood. So it's a big job. for country teams Uganda, Kenya, South Sudan, Tanzania, Somalia, Ethiopia, Cambodia, and Haiti. And the second member of the team is Sona Singh, who's been project manager at Action Against Hunger in Cambodia for the past 6 months. Dr. Singh. She is a PhD in pediatrics and international nutrition and conducted research focusing on undernutrition in Cambodia. And Sona Sharma is the third member of the team, Social Behavior Change Advisor with the Technical Rapid Response Team and Action Against Hunger USA. And she provides technical support on social behavior change to Action Against Hunger country teams, and as part of the rapid response team of advisors through deployment or remote support. So with that, we will turn it over to Armel, Sana, and Sona. Thank you.
Thank you, Sarah. I hope I'm audible.
Loud and clear.
Right. So thank you for the introduction, and thank you to the earlier presenters. Great presentations. I will very briefly introduce the format. The 3 of us are going to be in a kind of a discussion amongst ourselves. So think of us as fishes in a fish bowl that you're looking at. Post that, we will have, so half of the session part is going to be a discussion between us, and the other half is going to be a discussion with you. So with all the participants. So without further ado, let me start with the first question. And Sunny, I hope you're there.
Yes, I'm here.
Yes, okay. So to begin with, take us all to Cambodia and the project area. So what is it that we're really trying to change there?
So in Cambodia, there is still quite a struggle when it comes to undernutrition, both among women and children. 1/3 of the children less than 5 years are stunted, and about 10% of the children less than 5 years are wasted, and about 23% are underweight. A similar challenge, both overweight and underweight, is also a challenge when we speak about women of reproductive age. And the reasons for malnutrition are often due to inadequate quality and quantity of nutritious foods, and also insufficient knowledge on the importance of nutritious diets. So what Action Against Hunger have been doing in Cambodia the last couple of years is that Action Against Hunger Cambodia has been responsible for implementing a nutrition and basic hygiene component within the multi-sectoral food and nutrition security MUSEFO project. The MUSEFO project is implemented by GSAT and it's funded by BMZ. The project has been implemented in 180 villages across 2 provinces. It's Kampot province and Kampong Thom province, with 19 villages in each province. The nutrition and basic hygiene component is using a care group approach at community level to drive behavior change within the communities. And with this, I would like to invite Amel to explain a little bit more about the care group model.
The care group approach, so it's a behavior change model that is face-to-face, implemented face-to-face, and it's Mainly, it's a cascade structure that allow us to reach all the target group we want to reach, which are the pregnant women and mother of children under 2. So we form group of women, and each group can elect their care group leader, and we will work with the care group leader together with the health system to train the care group leader on several topics on hygiene and nutrition, and the care group leader will, in their turn, conduct session with the group of mother, and we share with the neighbor, and they will do also home visit. So as you can see, it's mainly face-to-face, and it's mainly a way taking place on the field. So maybe Sana, you can tell us a bit about how the COVID crisis came to disturb a bit the programming and how it was adapted.
Yes, so if we take a little bit of step back, when the COVID pandemic reached Cambodia, we had the first case at the end of January, and then we actually didn't have any official confirmed cases for a couple of months until mid-March. We had a huge increase, and in relation to that, the local authorities was quite quick to act on this. So for more or less within a couple of days, when the number increased in confirmed cases of COVID-19, the local communities, so village chief, communities and so on, said we were not able to go to the provinces, especially in Kampot, where there were some confirmed cases. We were not even able to do home visits. Where Kampong Tom, we were still able to do home visits, and therefore, to do the home visits, we developed a SOP, a standard protocol, to include preventive measures of COVID-19. So this including social distancing, extra hand wash, and also wearing masks and so forth. But because we were unable to go to the field for majority of our activities, we had to think, how were we then able to reach our beneficiaries? We had no idea how long this would go on, as every other countries. This could be weeks, it could be months. So we had to come up with an idea on how to solve this. In Cambodia, Facebook is quite common use. So the two project officers and we sit down and said, okay, we'll develop a Facebook page and develop some project related content. So we did we made the videos of the content for the care group sessions to post, and also we used the Facebook page to share information when it came to COVID-19, all official information about COVID-19 from the Ministry of Health and NGOs. And from the Facebook page, the field staff, the community mobilization experts, they developed some Facebook groups with their beneficiaries in their target area. It varied a little bit between the two provinces, but the whole idea was that the community mobilization experts created the groups, and then they shared the content from the Facebook page in these groups where the beneficiaries could review it. Some different Facebook groups were made. For example, there was made Facebook group with care group leaders and care group members, and also with provincial partners. And then they could share the content, and we develop an system, an M&E system, on how we can check how much of these activities or videos have actually been had actually been reviewed, to get some feedback. Yes, and then the households were able to share it. Sometimes it was the Facebook of the beneficiaries, sometimes it was a family member's Facebook or a neighbor Facebook account, depending on if they had a mobile phone available. Yes.
Okay, thank you, Sana. Maybe So, Sona, you can tell us a bit more about how the team have been transforming the face-to-face session into video. What were the challenging and what was done to address the issue?
Thanks, Armel. Yeah, as mentioned by Sane, the team really turned into filmmakers with this initiative. The challenge of continuing the care group sessions, the lessons, and along with the movement restrictions in place, that was resolved by producing videos which were scripted, directed, acted, and shot by the team themselves. So, and when they posted the first few videos, they obviously checked for responses from the care group leaders and from the members of the group. And the one response they got was, amongst the many, of course, was that the audio was not very audible, was not very good. So, and then the videos were a little too long. They wanted shorter videos, they wanted clearer audio. So and the team got together, and that's when we decided to do a little training. There are a whole lot of online free tools, video editing tools that are available. So we did a training in 3 sessions of 1.5 hours each, with practice sessions in between. So that they could, and this was not just a training on the video editor, but also a training on how tips to improve the quality of video shooting, even while using a mobile. So they could use very easy, user-friendly software. I mean, the picture here looks a little complicated, but they are easy softwares, believe me. But then after that, it was really amazing to see how creative the team got in terms of the editing. And I just want to show you a very quick sample clip in the next slide. And so this edited clip is actually an edit of the edited clip, and it was done during the training session. So it's still not perfect, but it'll just give you an idea of the kind of techniques that they learned to develop. I don't know why the slides are not moving. Okay, here we go. So that was just a little sample. And I think I'll get back to Sane now. So Sane, can you please share what have been the challenges, and what would your advice be to other organizations who would like to replicate something like this?
Thank you, Sona. So the challenge we had was, one thing is, it was new to the team. We were just learning by doing. They did an amazing job. But one of the things was that quite the rates of care group members and care group leaders having smartphones was not as high as maybe we had thought originally. And also one of the challenges, after we started to establish a Facebook group and we posted the first videos in the groups, the team found out that some of the beneficiaries were not so familiar on the technology. So they had to have a little bit of training, which was one of the things that both the beneficiaries was encouraged to join for family members on or neighbor's phone if they didn't have a smartphone themselves. And also after the field staff found out that there were some challenges, that the beneficiaries was maybe not familiar on how to use Facebook and how to view these videos and respond with the, for example, and thumbs up when they had seen the videos. or the post. They quite quickly followed up with the care group leaders and care group members on giving them a short introduction on how to use and how to respond to this. And also one of the things after, to respond to the question that was asked by the previous presenters, in session in number 2, one of the things where when we were able to go back to the field, we developed these SOPs, including extra COVID-19 prevention measures. And including in that, we also promoted information about the Facebook page and collecting Facebook names and phone numbers in a way to try and increase the reach. And I would like to make a quote from one of the field staff on what they thought about all during this, about the Facebook page and Facebook group suddenly going from being in the fields every day to suddenly have to sit behind a computer and a camera and try and develop scripts for these videos. So one of them said that in the beginning, we thought it would be impossible to connect with the care groups on Facebook, as we knew that the care group leaders and care group members had limited knowledge of terminology. As we started working on it, we realized that it's not only possible, but it adds value to the project activities. And this is one of the things I know the team recommends, that future projects already in the beginning start considering how can Facebook and social media be included into the reach of field activities and project activities. So that would definitely be a recommendations for future projects. They're starting up now because of COVID-19 or response to COVID-19. And one of the things is it was quite an immediate response. So of course, getting Facebook names and so on was a bit challenging, especially in the province where there was less accessible. So already think about the initiative in the beginning and collect the information needed. And then have some structure and clear guidelines also on who is responsible for managing the care groups, and also what can be posted in these groups to make sure that I know in Cambodia a lot of untrue information is spread about many things. And of course, we wanted, as Facebook groups, everyone can post in it, you want to limit these information. So there needs to be some overviews and regulations of these groups. Someone needs to be responsible for that. So we have written up a summary document on the approach, of the learnings of the approach, which will be copied into the chat box to share it with everyone. And yes, then I will pass the rest off to Amel.
Yeah. Thank you very much, Sana. It was a very nice presentation. I am very congratulations to the team as well. And it was they have been very proactive in adapting and making things work. So it was a very nice initiative. I will invite the participant to pose their question in the chat box. And in the meantime, maybe Sona, you can tell us a bit more about the TechRT and what is your role, and if other NGO or organization would like to receive the same kind of support, how we could reach to you. Thank you.
Sure, thanks, Armel. Yeah, and so this is the, I think we have a little less time, but please do post your questions on the chat box, and we will come to that, the questions post this. Just to give you a little bit of information about TechRT. So the TechRT is a rapid response mechanism which supports improved nutrition programming. We have a team of 4 deployable experts, and the technical assistance is provided through deploying advisors, remote support, as well as capacity strengthening initiatives. It is the TechRT is managed by a consortium of which is led by International Medical Corps, and with Action Against Hunger and Save the Children as the consortium partners. The kind of expertise that we do provide right now is on surveys and assessments, community-based management of acute malnutrition, infant and young child feeding in emergencies, social and behavior change, which is the support that I provide. And we have the flexibility to find others if necessary, and to request for any more information or even support, you can write to techRT@internationalmedicalcorps.org, or visit our website and follow our Twitter. So that's a little bit about techRT. I think I will stop sharing here, and should we go to are there any questions?
Great, thank you very much to your team for that excellent presentation, and your management of times for every session was magnificent. We actually have the grace of a few more minutes before the larger sessions begin, so we can take some questions. And there is a question in the chat here regarding, let me see if I can pull it up a little bit. Access to technology. It's from Carolyn Moore to everybody, particularly to MUSEFO's project. Households with, have you found that the shift to social media made it easier for some participants to take part since they could fit it into their schedules? And were there other barriers to participation other than technology?
I will let Sunny answer that.
Yes. So yes, indeed, some beneficiaries reported it was very convenient that they could see the videos when they had the time and they were available to do it. On the other hand, some also gave the feedback because the phone was not always in their own hands. Sometimes it was children playing with the phone, or they access it through the husband phones, for example. So sometimes they didn't have access as frequent. Sometimes a missed post, or if it was a child who had the post, sometimes they have seen it and then the mom missed the post. So that was, of course, the big scale. But generally, they were very pleased with the initiative, and also, especially the COVID information as well, that they had some official place where they could find the relevant information they need. And yeah, the time and not always being on Facebook as much as, for example, most European, for example, is of course a challenge. So there was more, sometimes a gap between how often they saw the post and so on.
Great, thanks. We have another question related to TechRT. Have you found that the demand for your services has increased with COVID-19, and have you changed your methods for providing assistance? That's for you, Sona.
Yes. So yes, we have changed our methods. The deployments are have not been possible of late, and so we have. The entire team has sort of pruned our skills on online training and providing remote support. We have got special training for that as well. So a lot of the support is now remote and online, and will continue till the restrictions continue, I suppose.
And have you found an increase in need or request for services?
Well, not substantially, but yes, there has been an increase in the need for resources and the need for information, and I think there's such a deluge of information already online that it is a little confusing for people. So that kind of specialized support is something that we can provide. We can tailor the support to the needs.
Yeah, great, thanks. Well, we've reached the end of our session. I want to say thank you very, very much to all of our presenters today. Really interesting and comprehensive discussion, or sort of presentations that are quite multi-sectoral, but show how things can weave together. And it's great to see these solutions. A lot of it seems to be a bit organic and that we're figuring it out as we go, but there are resources out there and people we can tap into. So Thank you very, very much. And we will go ahead and encourage everyone to hop back into the plenary by returning to the website, that the conference website, which Caroline put in the chat here. And thank you all very much for a great session. I look forward to seeing your materials come out, made public. Thanks, everyone.
Thanks, Sarah. Thank you for your
Thank
great
you. Thank you,
facilitation.
Sarah.
Thank you.
Yes, great facilitation, Sarah.
Thank you.